All right, good morning. Started. So we're really excited to have our first presentation here today. Not optional, PERT. I'm really honored to introduce Poppy Kazvis today. She's a registered dietitian and faculty lecturer at McGill University School of Human Nutrition, specializing in supportive cancer care. With expertise in dietary assessment, counseling, and pancreatic enzyme therapy, she has focused her research and clinical work on improving quality of life for pancreatic cancer patients and advancing care for pancreatic enzyme insufficiency. Poppy also completed her PhD, so we're really excited to have her here today. Thank you so much, Poppy.
Thank you. Hello, everyone. I'm really pleased to be amongst you here this morning. Yesterday, unfortunately, was a huge travel day. I didn't get to join in all the talks, but thank you. But I'm glad to share a little bit about what we do as nutritionists. And when I got the agenda of the program for the conference and I saw the title that was given to my part in this, not optional, making nutrition PERT standard treatment pathways, I was like, yeah, that's the ticket. That's the way we should be looking at things. And I do feel like I'm maybe preaching to the converted already, but I'd like to give you tools and some information just to basically get that message out, how this isn't optional. This is important in the care of our patients. So I have no conflicts of interest to report. Just to give you a little overview of what we'll talk about today. So I'll give you some statistics. I'll give you a good case for why nutrition management is not optional in these patients. We'll talk about how we could manage PEI. We could talk about nutrition management. I'll just give a little overview of a proposed PERT pathway and some take-home messages for you to take back to your places of employment. So I just want to go through, because I wasn't here yesterday, I want to get a sense of who's in the room today. So we'll just have, hands up for each of these professions. And I wanted to say that this talk will be very interactive. Please interrupt me if you have questions or if you want to say something. We don't have to wait till the end, okay? So we'll make it a discussion. So are there any dietitians in the room today? Just me? Okay. What about oncologists? How many oncologists? Okay, wonderful. How many surgeons? Lovely. Any nurses? It's here. Wonderful. Any other allied healthcare professionals, OTs, PTs, psychologists? No. Researchers? Wonderful. Any students? Okay. Any patients or patient advocates? Yes, very important. And I'm particularly happy you're here. Again, preaching to the converted. Very wonderful. So a couple more questions. So for those of you working in cancer centers, show of hands, in my hospital, there is a nutritional screening of all patients diagnosed with pancreatic cancer. Lovely. There are dietitians who are able to see patients before they get their surgery. So there's prehabilitation programs in your hospitals? Yes. Amazing. What about after surgery? Post-op care. Beautiful. During the treatments? Yes. Awesome. All patients with pancreatic cancer on pancreatic enzyme replacement therapy? The majority. Good. You see, this is what I'm saying. I'm preaching to the converted. That's not the case everywhere, right? I think we're all very aware that this isn't the case in all centers. So just to give you a little bit of background, some statistics, we'll talk numbers. Last Monday, the new cancer statistics were released. Of course, there's no real big change in pancreatic cancer. About 3% of new cases were pancreatic cancer last year. I believe it was last year in 2024 that pancreatic cancer became the third most deadly cancer, being now breast cancer. So that has not changed either. Buried in the text of the statistics was this sentence that just sort of put a chill through me. Because of the low survival rates for pancreatic cancer, the mortality rates are almost as high as the incident rates. And I think we all see that in our practices. Just seeing it on paper, I thought was quite telling. And you see that in terms of cancer deaths, pancreatic cancer knows no age. I was looking to see if I have a clicker up. Okay, wonderful. No age is spared, about 7% deaths from pancreatic cancer across age groups. So it's really nasty, as we know. The data has not really moved in the last few years. So some other numbers about nutrition. Okay, so 80% of patients have reported a recent weight loss, an unintentional weight loss diagnosis. So they come into your clinic, they're already losing weight. 66% of patients have anorexia and are actually malnourished that same visit. 71% of patients may have, or up to 71%, the range is quite large, but up to 71% may have cachexia at diagnosis. 25% of patients are receiving medical nutrition therapy. That doesn't make any sense. We have this high prevalence of malnutrition, cachexia, patients losing weight. And yet in a study from Australia, DeFerris and all found that only 25% of patients were actually seeing a dietitian. So there's a disconnect there that really doesn't work. So I'm going to lay out a whole huge data bomb on you guys about why nutrition interventions are not optional. So in this review from Ponce de Leon that was recently released about the effect of pancreatic cancer on the gastrointestinal tract. So you see this web of all sorts of issues that occur due to the cancer. And there were three that, for me, really spoke to nutrition, things that dietitians could work at. So they say anorexia, cachexia, nausea, vomiting, diarrhea, and steatorrhea. And I just also want to mention that both this paper and my talk were not focusing on quality of life outcomes, which are very, very important. Does all the psychosocial and socioeconomic problems that may affect nutrition as well. I'm really just going to keep it to the two treatments for today, just in terms of time and scope, because that could be a whole other talk. Okay, so from that Ponce de Leon article, I decided to look at this Venn diagram of nutritional issues related to pancreatic cancer. So cachexia and sarcopenia, cancer treatment and related symptoms, and PEI malabsorption or pancreatic enzyme insufficiency. So we'll start with cachexia and sarcopenia. So the classic definition from Ken Fearon back in 2011 is that cancer cachexia is defined as a multifactorial syndrome characterized by an ongoing loss of skeletal muscle mass with or without fat mass. Now we know with fat mass as well, that cannot be fully reversed by conventional nutritional support and leads to progressive functional impairment. And I'll show you why we can't just tube feed a patient and reverse the cachexia. I'll show you that in a second. The pathophysiology is characterized by a negative protein and energy balance driven by a variable combination of reduced food intake and abnormal metabolism. So in this review from Puglia in 2020, really focusing on cancer cachexia related to pancreatic tumors, we know that the crosstalk between the tumor and the immune system is the main driver of systemic inflammation. There are also tumor-derived inflammatory cytokines that are released as well, and they have a horrible effect on the gut, of course. Malabsorption and fat steatorrhea is going to be the real main focus of my talk today. We know that there's a huge anabolic resistance. There's insulin resistance leading to loss, leading to sarcopenia. And of course, that is related to decreased quality of life. We have a hepatic dysfunction with a huge increase in acute phase proteins being released in this inflammatory context. We have the browning of adipose tissue, which leads to futile cycling and ATP use, burning energy like a motor, just burning that energy with and this leads to lipolysis and lipid utilization as well. In the meantime, the white adipose tissue is also undergoing lipolysis, and lipid utilization is increased, leading all these factors lead to the weight loss that we're seeing. My personal interest is what's happening at the level of the CNS system. the anorexia that is so prevalent in our patients and so profound and so, as a dietitian, very difficult to deal with, to get around, to offer solutions to the anorexia. And when we look at the pathophysiology of why this is occurring, so we see that the inflammation, IL-6, the IL-1 alpha is really triggering these orexigenic neurons, so the neuropeptide Y and the agouti-related proteins in the hypothalamus. So turning these off, they are gone. In the meantime, the anorexigenic neurons, those that make us feel full, that our appetite, POMC and CART, those are switches. It's very difficult to turn them, to change them. So that's happening at the level of the hypothalamus. So when you're in clinic and the patient says, I can't eat, I'm hungry, I have no desire to eat, this is what's going on. It's not them being difficult, it's not just the treatment, okay? It's really at the level of the brain. And in the meantime, the brain itself, the hypothalamus is releasing IL-1 alpha, which is an inflammatory cytokine that triggers the pituitary hypothalamus adrenal axis, releasing cortisol, and these corticosteroids also have a profound effect on muscle wasting. So we see all these issues, this inflammation is systemic in nature, and it's causing degradation in protein stores from many levels. If I'm to, we can't see it here, unfortunately, because my face is ruining the slide. If we, thank you. Slide, but that's okay. So if we're to compare starvation to cachexia, and I love to teach this to my students because this is the difference, the way to differentiate the two. Starvation you could change, okay? Starvation you could change. You feed a person, things will go back to normal. Cachexia you cannot. The main difference is sort of going back to what's happening the level of the protein degradation. So we see here when we're starving, our metabolism slows. We're not using the fats, we're not getting into this browning of adipose tissue, into this futile cycling usage of ATP for nothing. So everything slows down, our metabolism slows down. That's not the case in cachexia, okay? And you see this cortisol here from that triggering from the hypothalamus. So very different things. Very different things. They're not treated in the same way. More on cachexia. So Ken Fearon also gave us the idea that cachexia is within a continuum. So we have our pre-cachectic patients with weight loss of less than 5%. Maybe there's anorexia, metabolic change, but it's not sure. And this is actually something that's very hotly debated in the literature because you could argue that everyone is pre-cachectic. What is pre-cachexia? It's not very clear. Cachexia becomes a little bit more clear, so we're giving it a weight loss of 5% or more, or BMI of less than 20. And then we're seeing the anorexia. It's the reduced food intake, systemic inflammation, okay? These, as a dietitian, I need a CRP. You know, we need those blood tests to sort of start thinking about, well, is the inflammation present? This has been an argument in our center. I don't know if it's an argument in other centers, but this is very important information, knowing what's going on with the inflammation. Pre-cachexia and cachexia may be reversible, may be slowed. Treatments do a lot to help. So once the patient is on chemo, the inflammation may be reduced, so the cachexia sort of slows down. A patient might start getting their appetite back. Things might be looking a little bit better. Once we get to the refractory cachexia stage, this is all the things we've seen previously, the weight loss, the muscle loss, the anorexia, but now we have a functional decline. So our performance status is dropping. This is end stage. This is not reversible. At this point, we're some palliative methods and thinking about comfort care, quality of life. So until like in these two stages, we're throwing a book at our patients. We're trying everything. Once we get to refractory, we've got to reevaluate what we're doing and whether it's benefiting the patient. What are their preferences? So this meta-analysis from Dundonald just released last year shows the prevalences of patients with pancreatic cancer with cachexia using the Fearon criteria or a weight loss of greater than 5%. So they lump them all in together and we see the prevalence rates. Most of these studies showed over 50%. So going with that big range up to 70% of patients that I showed you earlier. And we see, again, in the Dunn article, we see the outcomes on mortality of cachexia. So almost all the studies showed a higher rate of mortality, hazard ratios above the 0. So moving on to sarcopenia. So when I was doing my PhD research, we were using different sarcopenia definitions. Things are evolving quickly in this scope. So at the time, we were using those from the sarcopenia in older people. Characterize sarcopenia as a threefold problem. So there's muscle wasting, there's muscle strength or decreased strength, decreased function. But since then, so in 2024, Kirk and including the people who were on the European Working Group, they released new information that they obtained through a Delphi consensus about what sarcopenia is. We need a working definition, just like cachexia. It's very hard to understand and treat things when we don't agree on how to define them, okay? So their working group sort of has changed sarcopenia a little bit, or the definition of sarcopenia. They're talking about muscle mass, muscle strength, and muscle specific strength. So muscle strength to actual muscle size. Muscle size. So if you talk to a physiotherapist or an occupational therapist, they'll talk your ear off. I'm telling you, it could be hours about why this makes a lot more sense than using just functional outcomes. And I've had those talks, so that's why I could tell you this from personal experience. The only issue I have with this is that it's how are we ever going to measure that in the clinic? So that's a little bit of something to work on, but at least we're towards what we agree on. Research sphere, this is doable. So prevalence has been reported of sarcopenia in patients with pancreatic cancer, so at about 40%. Of course, it is higher in those towards end stage. So if we think of those with refractory cachexia, they're losing a lot of muscle, they're losing their function, so that makes a lot of sense. And in this earlier study where they sort of used this Venn diagram to characterize BMI with sarcopenia, I thought this was very interesting because we see the underweight people in this end of 111 were sarcopenic. The people BMI with normal range, still quite a few more were sarcopenic than not. And then we talk about the overweight and obese patients, of whom 16% were sarcopenic. And I want you to keep that in mind because that's a complicating factor, and we're going to talk a little bit about that in a couple of slides. So overall survival, again, sarcopenia is related with mortality. So I'll focus on the palliative patients here. We could see that mortality rates are lower in those who do not have sarcopenia. So just a word about sarcopenic obesity. I like this infogram from Prato et al. That shows really how sarcopenic obesity is not necessarily obvious. Okay, so we have someone with obesity or obesity, but this is low. We could, if I, as a nutritionist, am performing a nutrition-focused physical exam where I'm trying to feel for the muscle loss or the fat loss, it's very hard, very difficult to do just with my hands. It's like you get a sense of it in talking to the patient, putting the whole picture together. You could understand it, but just blindly trying to figure it out, it's not easy. And I'll give you oh, okay. Sorry, there were voices in the room for those online. I wasn't sure if they were in my head. The, just a little clinical, one of my experiences with sarcopenic obesity. We had a woman come into our rehabilitation trial. She was awaiting a Whipple surgery. She was obese. She had had bariatric surgery in the past, but had regained the weight. And she was so weak. I can't even tell you. She used to tell us how she had a hard time opening the door of her dryer. She had to ask her husband to do it because she could not open the door of her dryer. And this woman looking at her, you would not expect that. When we did the tests, we saw it immediately. Um, by the end of the 4-week trial, she had gained enough strength and she was so happy because she could open her dryer door. I mean, it seems like such a small thing, but for her, it made all the difference. It made all the difference. So just looking at a patient, you're not going to see it. You need to do a little bit further investigation. And here's a question for you all. In your centers, when your patients get their CT scans, is anyone looking at body composition through the CTs? No one. Yeah. I wish we would. I wish we would, because look at what you would see. You would see this underweight person who has normal muscle mass. So make sure you look at the psoas muscle to characterize sarcopenia. Thin as a rail, but normal muscle. She's probably fine. Strength is probably fine. Look at our obese patient here. Look at how the muscle is degraded. You can't see it. We need to work on getting these CT scans read, or even when dosing chemotherapy, we're dosing on body surface area. No wonder these people have toxicities. They have no muscle to metabolize things. So I love this picture from Fearon's paper. So what are the outcomes of sarcopenia? So we have in cancer patients on the whole. So we have our surgical complications, we have prolonged length of stay, we have decreased tolerance to therapy, and we have decreased overall disease-free and occurrence-free survival. And in patients with pancreatic cancer who have sarcopenic obesity, we could see a twofold risk. So I'll move along to cancer and treatment-related symptoms. I won't spend much time on this because I think we all are quite aware of these. So, of course, pancreatic cancer causes a whole bunch of issues just having this cancer, including pain. So that massive pain, that bar across their back coming in the front, it's really difficult for them to deal with that pain. Of course, there are gastric outlet obstructions, both at the antrum and duodenum. There's pancreatic exocrine insufficiency, which we'll focus on today. That could be tumor-related or surgical. And of course, the diabetes that, again, may be tumor-related or surgical. And our lovely therapies right now have a constellation of side effects associated with them: anorexia, nausea, vomiting, diarrhea, constipation, mucositis, dysgeusia, fatigue, early satiety, et cetera, et cetera, et cetera. And again, not to belittle the psychological impact, but that's beyond the scope of today's talk. And then we have our pancreatic enzyme insufficiency. And I'm using PEI, but you'll see we're going to switch back and forth because I'm going to present some guidelines that uses EPI, same, we're all talking the same language, and malabsorption. So what is it? Inadequate delivery of pancreatic enzymes and bicarbonate to the duodenum, resulting in maldigestion and malabsorption. PEI occurs in about 70% of patients with pancreatic cancer. It's not negligible. And it is most common in patients with tumors located in the head of pancreas and those with advanced stages of disease. So just a little refresher, we have our exocrine pancreas, we have our endocrine pancreas. So the endocrine is responsible for insulin, glucagon, and statin. We're not going to really talk too much about diabetes today because, again, that could be a whole other talk. We'll focus on the exocrine insufficiencies. So we have elastin cells with releasing digestive enzymes, the ductal cells releasing the bicarbonate. And to keep it very simplistic, if the food is not digested by the enzymes because the tumor is blocking it, because we've had a surgery, because the food remains intact. There is an osmotic effect bringing water into the intestine, and that's where we see the diarrhea and the gas and the bloat and all the lovely side effects of PEI. So what causes PEI in pancreatic cancer? I love this review from Powell and Brett. They did a really good job sort of bringing this down to a very comprehensive level. So we have surgery, so just losing parenchymal losses due to the resection. We have the cancer progression, so obstruction of pancreatic ducts. So it's important to remember that PEI could get worse as the disease progresses. So we might be giving a certain dosage of PERT at the beginning, but we might need to increase as the disease progresses. Duodenal resection, reconstruction issues that may alter the physiology and may affect enzyme delivery, denervation, which also just might cause an asynchronicity between the gastric emptying and secretion of enzymes. So symptoms of PEI. So Barkin's article actually gave some frequencies, which I thought was interesting. So abdominal discomfort being the most frequently reported, diarrhea, weight loss, stool color, steatorrhea, bowel urgency, flatulence. So these are all things we could keep in the back of our minds when we're assessing for PEI. Is my patient reporting any of this? Do they have pancreatic cancer? We might want to treat. So I'll get to more of that later. Another way of looking at it is early symptoms and later symptoms. So when you get to the steatorrhea, they've been malabsorbing for a long time. We cannot wait for steatorrhea to appear before we start treatment, okay? Which I think in the past is what we would do. And of course, we have testing. So does anyone actually do testing for EPI? No. I don't even think we could do a fecal elastase at the NHC. We have to send it out to one of the children's hospitals. So no, we're not doing it either. And there are a lot of issues with the testing. Most of them are indirect in nature. The CCK secretin test is horrible. It's invasive. Like we don't do invasive tests on this population base for nothing, because we could probably assess just using symptoms, looking at weight loss. It's maybe not the most highly specific and sensitive, but I think it's okay to do, given the paucity of available testing. Some of these tests require patients to eat tons of fat before being tested, which will just, for 5 to 7 days, I believe, which will just make your lives miserable for what? So I think we're good. It's nice to know that these exist, and maybe in a research context, it might be a little bit pertinent, but in terms of clinical practice, it's kind of neither here or there. So I'll ask that. Jump the gun. Okay, so managing PEI. So what are some tips that you could take home with you today? So we were blessed this year with 2 guideline papers that came out. So one from Europe, which includes Dr. Dominguez Munoz, who has spoken at this conference before. And one from the Americans. So we have the study from Canopy that was backed by Pancreatic Cancer Action Network. And so I'll go through basically what the 2 guidelines say, how they are similar and how they differ slightly. So they both agree that screening, well, sorry, actually, no. Every Americans talk about screening for EPI. Color EPI. So they should all be, patients should all be screened at diagnosis, and they should be rescreened. So going back to as the disease progresses, we know that the PEI might get worse. So we do want to just keep an eye and see how things are going. So screening should start at the earliest sign of a pancreatic mass with clinical symptoms. And it should be ideally done before the treatment begins, because we know that treatments will cause diarrhea, will cause digestional problems. So we want to be able to differentiate the two. So let's screen early, day one. And they actually provide some screening questionnaires. So this one is patient generated. Neither of these have been validated. They're very new. But there's nothing wrong if you need something. If you don't want to just ask the questions, you can have patients fill out these two questionnaires. So the first question is about symptoms, and it includes many of the symptoms we've already talked about. And the second is describing the look of the bowel movements. So are they floating? Are they difficult to flush? Are they loose? Are they urgent? And as you can see, it goes on and on. Okay. And then there's a dietary question about foods that might be avoided and how much food they're eating. So have they reduced the amount of food they're eating because they're not digesting because it's causing pain? It hurts to eat. I poop after I eat every time. I can't eat. So these are all very important things to understand. And then they also offer a clinician tool, which includes the same 4 questions, but then asks questions about pancreatic enzyme replacement therapy or PERT. So they want to know how much are you on it, how much, and are you taking any pain medication? So these are important to assess your patient clinically. In terms of assessment, so the Europeans said that PEI should be assessed based on the combined symptoms, nutritional status, and pancreatic function in appropriate clinical context. And the Americans very similarly said you diagnose pancreatic cancer patients and through routine screening that combines an assessment of clinical symptoms and nutritional status. That should be enough. You don't need the pancreatic function tests. If we know there's a pancreatic tumor, that's enough. They also go on to say they give you a little bit of sort of outline of how you could assess the presence of PEI, which is very tangible and usable. So they say, is there weight loss despite the patient saying they're eating normally? And they have one of the symptoms that we talked about, gas, bloat, diarrhea, whatever it may be. So those 2 things, you should suspect PEI. Are there 2 to 3 PEI-related symptoms? Maybe the weight loss hasn't occurred yet, but those symptoms are there. If that's the case, then again, you should suspect PEI. So those are 2 very tangible ways to, think, oh, I better do something about this. Patients with PEI often have nutritional deficiencies, and nutritional assessment can aid in the diagnosis of PEI in patients with pancreatic disease or surgery. And the nutritional status of patients with PEI is evaluated primarily using anthropometric parameters. If malnutrition is suspected, blood parameters of malnutrition should also be assessed. So a dietitian is going to want the blood parameters as well. And this is, I think, one of the most important statements in the whole document from the Americans. The trial of enzymes is considered safe and effective in symptomatic patients with pancreatic cancer with or without an official clinical diagnosis of PEI. Just treat it. Someone has gas, they have pancreatic cancer, treat it. Okay, so just to get us moving, get our arms going up again, okay? So how many of you think this statement is true? PERT should be initiated in patients with pancreatic cancer only when steatorrhea occurs. No. Way too late. Way too late at that point. They've already been malabsorptive. PERT should be taken 20 to 30 minutes before meals. How many of you think that's true? I swear to God, people are still prescribing it that way. Still. It's a big fight in my center, and my colleagues is even teaching this. It's a big fight. So this myth is longstanding and it's hard to break. So I'm glad no one here is doing it. So dosing. So this is another place where there's a little bit of a difference between the Europeans and the Americans. So the Europeans are saying 50,000 units lipase per meals and half with SNAC, so 25,000 units, shows to be effective in adult patients. They do say that a higher dose could be effective in more severe PIs, such as after a pancreaticoduodenectomy or Whipple's. So they're sort of being, very cautious, 50,000 units. The Americans, on the other hand, say no, start with 72,000, 50 to 72, 75. Let's round up. And they also give a word about timing. So again, going back to the 20, 30 minutes before meal. So half the dose should be taken at the start of the meal and half taken at the middle of the meal. And we have data showing what happens to enzymes. What's the enzyme activity after, like, postprandially? So we see at zero, there's nothing before zero, okay? There's basal, and then it's at its peak into the meal. I don't know what your experience is with your patients. All my patients would eat very slowly, because they have no appetite. So it is important sometimes to consider if your enzyme prescription isn't working, maybe they need to spread it out through the meal to offer more coverage. That too is debated. I think that's an individual level. I think it's worth trying. So another question for you guys. So how much lipase does a healthy pancreas secrete during an average meal? How many of you think it's number 1,000 units? Number 2, 9,000? Number 3, 2,000. Yeah, it's number 3. So when we're prescribing 70,000 units of lipase, I think we're okay. We're not going to cause any harm. And I was just talking to someone about how pharmacists freak out when the patients come in with these high doses and they're just reading the monograph, right? And it's like they're worried about what is it, the colonic, what's that side effect called? Anyways, it's not happening. These patients will be fine. Okay, so dosing. Successful PERT can be defined as the resolution of nutritional deficiencies and relief of symptoms and signs associated with PEI. It's had the exact same statement in guidelines. I don't know if it's realistic that 100% of all symptoms will be gone, but there should be a significant decrease, and your patient should be able to come to you and say, oh my God, my bowel movements have decreased a lot. I'm able to eat again. I don't have all the gas. So monitoring. Patient education on PERT should occur at a time when prescription is given. And only the Americans said this. So education is very important. Enforcement over the course of your time with the patient is very important, making sure they continue to take the PERT as prescribed. The patient should be educated to inquire about increasing the dose if their symptoms persist, and offering them a sliding scale might be useful, okay, to allow them to self-dose. A patient on PERT should be routinely monitored for dose adjustments, especially within the first 2 weeks of initiating therapy, the onset of any new worsening symptoms. So we do need to keep an eye on because the weight loss is rapid, okay? And if we want to avoid quickly getting into that cachexia, into that sarcopenia, we have to nip the weight loss in the bud. And then active collaboration between the multidisciplinary team represents the best practice in the management of patients with EPI. I don't think any of us would disagree with that. We all have our vantage point on what is going on with these patients in terms of their pancreatic enzyme insufficiency. So let's do this little case study. I made it very easy. It's 8:30 in the morning. So 63-year-old male, diagnosed stage 2 resectable pancreatic adenocarcinoma on the head of the pancreas, weight loss of 10% of body weight in 2 months, frequent BMs, loose times twice a day, diarrhea times twice a day. The stool smells, it's yellow. Patient says he's eating 3 meals a day like always, same quantities. So Hands up, doesn't mean PERT. Again, preaching to the conversion. Okay, yes, of course he needs PERT. Yes, we don't want this to continue. And using those diagnostic criteria, so this patient had unintentional weight loss despite adequate food intake and one additional symptom. All right, so nutrition management. So what does that pesky dietitian in your team do to help these patients, okay? We'll start with a couple of true or false questions. So patients with pancreatic cancer must avoid dietary fats. How many of you think this is true? I still see this everywhere. No, we have to give them PERT. They should not be avoiding dietary fats. Patients with pancreatic cancer should eat large meals to maintain weight. Anyone think that's true? No. Small frequent meals is the way to go. We don't want to overtax the system. So where to begin? So as with everything, nutritional interventions, early intervention is key. And there have been a plethora of guidelines in the last 5 years talking about nutrition and cancer, nutrition and cachexia, that all say the same thing. When we talk about early intervention, we're talking about screening. I'm very happy that in your centers, the screening is happening. In our center, it sort of happens. Actually, the numbers lately have been terrible. We have to work on that. So screening is not happening. When I was in clinical practice, I worked in a cancer rehabilitation clinic, a very highly specialized cachexia clinic. First, patients were screened every visit, not even just the first one. Every visit, they filled out a form, and I'll show you the form we're using. So screening is a must. It should be performed in all patients, including those with pancreatic cancer, and it could be done by anyone. It could be done by a PAB or an orderly here. It could be done by a secretary. It could be done by a nurse. It could be done by a doctor. Ideally, and this is my little addition, ideally the screening results would be integrated into the electronic medical record. Is it integrated in your EMRs at your centers? Nutritional screening? No. In some centers, there's like a little flag that goes up that there's a positive screening. So it makes it very easy to find the patients that really need an intervention. And rescreening, just like for PEI, nutritional rescreening would occur at regular intervals. Is it every second cycle of chemo? Is it like when is to be debated? But we need to rescreen because things, especially in these patients, take a turn very quickly. So I'll just go over a few of the screening tools. Maybe you could tell me which tool you're using in your centers, if you know. Does anyone know? No, it's a dietitian's job to know. You need to know they're taking care of it. Okay, so we have a few that I'll just go over here. So the MUST screening tool, they use score, weight loss score, into the type of disease they have to screen. So of course, 2 or more high risk in terms of scoring. You could argue all day if these are the most pertinent measures, but at least it's something. It's something to start with. The NRS 2002, very much like the MUST, but they also talk about reduced dietary intake. So is the patient eating, which is important. The CNST, the Canadian Nutrition Screening Tool, so this is what the Canadian Nutrition Task Force in countries trying to implement in hospital centers. 2 questions can be done by the next door neighbor, can be done by anyone. Okay. Have you lost weight without trying in the last 6 months? And have you been eating less for more than a week? Very similar to the MST, which is a firmly established tool. So super easy. Okay. In our center, we go a little bit more complex. So we use the abridged patient-generated subjective global assessment, which is the worst name for anything. It's such a long name. This is patient-generated, as the title states. It is the only screening tool that's really been developed for patients, not the only one, sorry. It is the most studied tool that has been developed for patients, oncology patients. So it looks at weight changes, food intake, symptoms, which is what we know about, and performance status. So the ECOG is integrated into the tool. It's self-reported by the patients. So a lot of information in this one tool. So if a positive screen comes in, the patient should be seen by a dietitian. The dietitian will then be able to confirm, categorize the severity of malnutrition. Okay, and there are several tools that we use. There's one, the PGSGA, so it's just an extension of what I just showed you, which includes a nutrition-focused physical exam. It includes other stressors like cancer, fever. So there's to it to be able to really categorize the severity of the malnutrition, whether it's mild to moderate or severe. Oops, wrong button. The dietitian will also assess food intake. So adequacy, just overall, are they avoiding eating? Are they eating the right things? Are they following a fad diet? God knows we see a lot of that all the time. The dietitian could also assess the presence and severity of the nutrition impact symptoms that the patient may be experiencing due to the cancer, the PEI, surgery, whatever it might be, the treatment, excuse me, with a particular focus, of course, on bowel movements and everything like that. The dietitian could also help with the assessment of muscle mass, fat mass, nutrition-focused physical exam. We use hand grip dynamometry, use anthropometric measures. So we'll do mid-upper arm circumference measures, and there's some data published about cutoffs to sort of clinically be able to assess sarcopenia. Again, we can't do amount of muscle to, we can't categorize that yet in clinic. I don't know what they're going to come up with as an idea, but for now, these are the tools we have. In my clinic, I was very lucky. I was able to DEXA all patients. So I was able to see how our treatments were affecting body composition, particularly body mass. And we, of course, have our labs. And as I mentioned before, CRP is really integral in this patient population to see if we're actually getting into cachexia. So a nutritionist is well placed to assess what's going on with the PERT. If they're not on PERT, they want to suggest PERT. They want to make sure that it's being used appropriately. They want to assess the dosage and help with the titration. Same with if the patient's on other supportive meds. If they are nauseated all day, but they're not taking their antiemetics, the nutritionist could help encourage that and alert the medical team to the fact that they're not taking their supportive medications. Same with pain meds, same with antidiarrheals, whatever. So our intervention, so the guidelines state energy intake of 25 to 30 kcals per kilogram per day, 1 to 1.5 grams per kilogram per day. That's for general cancer populations. For us, we're talking the high end, patients with pancreatic cancer. We're going to make sure our patients are eating 6 to 8 times a day, every 2 to 3 hours. Take a bite. If they're anorectic, this is the only it's feasible. They cannot sit down and eat a whole meal. Then we're also going to provide guidance on optimizing the energy protein intake we're seeking, and it's going to be individualized and it's going to be based on tolerance, preferences of the patient. We can't make them eat kale as much as they think kale is super healthy. They're not going to start eating kale or tofu. That's my favorite one, tofu, when they're sick. Based on their cultural beliefs or foods, the foods that they're used to eating, their food literacy and the food security. That's a real issue right now. So we have to keep all this in mind when we're guiding them to these guidelines. And this is just some data from some work I did in my PhD in patients waiting pancreatic resection. So they were in a rehabilitation study for 4 weeks, which included nutritional counseling. You could see that we got the prehab group, we really got them to the 1.5 grams per kilogram per day. And the whole group included other patients receiving, they were getting sections as well. So it was HPV biliary patients. But within the pancreatic group, we saw an increase. So that was a good thing. Nutritional counseling works. So other interventions, other tools in our toolkits as dietitians, of course, we have our famous oral nutrition supplements, semi-unlimited formulas, so formulas that are broken down that include MCT oil, which does digestive enzymes, really help this patient population. In Quebec, and I know this isn't the case everywhere across the country, but dietitians have, if you take a training, you have prescribing rights for multivitamins, for vitamin supplementation, as well as oral nutrition supplements. So I could, if I see some sort of deficiency, I could treat it. I could also suggest medium chain triglycerides, so MCT oils, which enter the portal circulation directly, which doesn't require any enzymatic activity in the gut to absorb. So this is just a nice calorie bomb that we could help our patients who are losing weight. And of course, whey protein is another option to help with muscle. Counseling will help to ease nutrition impact symptoms. And if we see things really bad, it is, I feel, to advocate for the patients and talk to the medical team, ensure proper supportive medication. So, so the dietitian will also, as I mentioned before, get the PERT, recommend starting it, provide education on it, help titrate and ensure proper use and timing and adherence. And like I put this here, this is from the American guidelines, talking about maybe things that we're not thinking about that the dietitian will deal with. Simple sugars, you're having a bit of juice, you probably don't need to take PERT. Okay, if you're taking MCT oil, you don't need to take PERT with that. If you're taking just a bite of food you've eaten, like you can't eat anymore, don't take your 3 capsules of PERT at that meal you haven't eaten. You need to. So things like that that are very individualized, that the dietitian gets in the weeds with the patient because they're really talking about the food they're eating and their habits. I don't think the oncologists and surgeons have time to deal with this. So send it on over to your friendly neighborhood nutritionist. I know there's been some, I think in Nova Scotia now, is that correct, Stephanie, that the dietitians could prescribe PERT? Or it's being worked on? I know it was at least being worked on, if it hasn't passed yet. They're not yet. It just did. No, we're unsure. Okay, I'll clarify. We're unsure if in Nova Scotia dietitians have this prescribing right at the moment. We're not.
Dietitians in Nova Scotia are authorized to prescribe pancreatic and plasma replacement therapy, provided they meet specific authorization requirements set by the relevant court body.
Beautiful. So Nova Scotia is ahead of the game in this one, which is great. I know this is huge. Dietitians in Quebec very jealous. I know our professional order is working on this to get us prescribing rights, because right now I could only prescribe enzymes to unblock a tube, but a feeding tube, but I can't have someone put it in their mouth. So it's ridiculous, but everything takes a long time. So we're working on it. It'll be standard across the country. Again, to the team-based approach, oncology dietitians are essential. The pharmacists, we have to educate them as well a little bit about looking at that. And I just want to give a shout out to the profession, because we have the time, because we are getting the weeds about everything. I know you worked with the doctor. I worked in the cancer rehabilitation clinic. I worked with a palliative care doctor, and he was the one responsible for the PERT. He didn't want anything to do with it. He left it to me, and It's really because I was able to see the whole picture. Okay, and he could deal with pain, for example, very important things. And just to, because it's not just my work, I'll give you some data supporting for the dietitians dealing with this. So in a very large UK prospective study, we saw that dietitian referral led to 76% of patients being prescribed PERT compared to the 20% who did not see a dietitian. Surgical candidates, it was 87% compared to 34. And the non-surgical candidates, so the ones that probably did 70%, so still pretty good, 16%. Even in those seen by a clinical nutrition specialist, it still didn't get as high as the dietitians. So the dietitian is taking the time to assess everything that's surrounding the PERT. So this is my plea for my profession. Of course, then we'll also work just to optimize glycemic control and changes to OHAs or insulin that is required. Nutrition support. Sometimes patients just can't eat preoperatively to be optimized nutritionally. Then we could consider enteral or parenteral nutrition. Of course, enteral is always preferable. We start there. And we do this in patients who have a prognosis of a few months. We don't want to do it in a palliative setting. It causes more distress than help. And if the prognosis is less than 6 weeks, or if the patient has refractory cachexia, our interventions are really guided towards comfort care, quality of life. In our clinical guidelines, it is clearly stated that dietitians should be openly talking about cachexia. We should be using that word. We should be explaining to patients what is going on to the severe anorexia that causes so much distress. I am not qualified to be a marriage counselor, and I've been a marriage counselor more times than I care to admit because of people fighting about food. Talking openly about eating related distress. This is very anecdotal just upon my clinical experiences, but analyzing what the patient is feeling. The caregivers understand is such a huge important of dietitians, I think. So monitoring, of course, when patients come back to our clinics, we're going to take their weight, we're going to look at their food intake, how it's changed, have they implemented the suggestions given. We're going to look at their PERT use. Are they using it appropriately in terms of timing and dosage, in terms of foods it's taken with? Are there nutrition impact symptoms? Are there some changes in laboratory results? Of course, we're going to adjust as the disease progresses and with patient-centered recommendations. So I'm glad to see, I don't think anyone is in this situation here. But of course, Craig's Cause has so much information on their website. Could shunt your patients towards Craig's Cause for nutritional help. We have the PERT Calculator now that Stephanie is going to talk a little bit about once I finish my presentation. This helps patients. I honestly think for patients who have no access to a dietitian, what a tool this is. They can put in the foods they're eating. I'm eating this and it's causing me distress. I don't know why. People don't know it contains fats. I can't tell you how many times a patient has told me a banana contains fat. There's no fat in banana. So, food literacy is a real thing. And, having this tool is a great resource, especially for patients who don't have access to a dietitian. And then for general nutrition recommendations and cancer, of course, we have the Canadian Cancer Society, this wonderful book, Cancer. So the proposed PERT pathway, I actually don't know where we're at, Stephanie. So if you want to jump in, I just have these few words to say about it. So we're looking to create standardized guidelines in the Canadian context based on the expert consensus of people at conferences like the NPC. to disseminate these guidelines to healthcare professionals across the country, all the way from primary to tertiary quaternary care. Get them in the family doctor's office if we can. Sensitize people for the family doctor seeing survivors, what to do with PERT. The PERT pathway will have 4 steps. So to assess, prescribe, monitor, and educate. So more to come. There we go.
So it is in your packages, and after this talk, I just made some notes. I'm gonna ask for them.
I don't know if it's still a work in progress or if we've gotten over the semantic issues we've had, but so anyway, but it's coming. So, and you have it in your packages to take a look at. You go ahead, Stephanie.
We put in Poppy when you were talking. So it's just in red, and we've Viatris is the reason we have a PERT calculator. Through their unrestricted education grant, we created the PERT calculator through their unrestricted grant. So we had PERT calculator 1.0. We then surveyed all of the users. So I think we had close to 2,000 users within the first year. So in 2024, we found that. So the first one certainly had areas that we could improve upon. So we had 85% said they would recommend using the PERT calculator to other patients. And there's over a 40% increase in the increase in the amount of PERT that they were prescribing. But a lot of the patients are still saying that there's a lot of conflict with the prescribing. So patients regularly talk about using PERT 3 pills in the morning, 3 pills at lunch, 3 pills in the evening with like the bubble packs, or they'll go with their prescription to the pharmacy, and the pharmacists are the ones saying, whoa, that's way too much. We can't prescribe that much. And then there was certainly, I think Aaron had talked, or there was another patient talked about, maybe it was talked about the access of PERT. We also had, patients that talk about, especially in the states that come to some of our sessions, talk about cutting down the PERT so that they can afford the PERT, or they do some on-label PERT and some off-label PERT to be able to prescribe, to be able to sustain the costs. I also don't think we put in here, Poppy, about the CT body composition. And I'm wondering if we should put that in the guidelines, maybe for assessing.
To be discussed.
To be discussed, okay.
That would require a huge,
okay.
Yeah.
Well, if they have, yeah, we'll talk about it later, but you're saying like if they have the CT scan, can they also monitor for that body composition at the same time they had their CT scan? Anyways, just some notes I'm taking. So it is in red, it is a draft. We've spoken with Viatris, and there was some discussion around when you take PERT. So Aaron, maybe you can speak a little bit, because Jessica, I think you're gonna have to come up and say what about Jessica, another nutritionist, just because you have a better understanding of this. But when do you take PERT? So because PERT's gone through, and you can step in Health Canada regulations based on certain wording, we had to play around with the words, so it went with Health Canada, but also went along with what nutritionists were telling patients.
The problem is that it's very nebulous. It says take with meals. What does that mean?
Yeah.
To me, take with meals could be at the beginning. It could also be at the end. So that makes a big difference.
So we put in our guidelines, PERT should be taken before the first bite of food. And with
the first bite of food.
Yeah, with the first bite of food. We have before, so we have to change that. With the first bite of food, with the initial treatment of at least 40,000 USP units.
We have guidelines now that can use that.
Oh, you can talk about there's a little bit you think that?
Oh, just around, I know you had mentioned, Poppy, that it's like kind of personal, the PERT, like whether you take it like halfway through and at the beginning or just at the beginning. So I think that was all that we were, one of the other dietitians.
For example, I know Jessica doesn't see the need to do it in the, but I've had, again, it's a trial and error thing. I wouldn't prescribe that to all patients at the beginning. Patients should start with taking their whole dose at the beginning of meals. And then if things aren't working, if we feel we've titrated up and things aren't working, then I would start spreading it out in the meal. And again, based on what is the patient telling me, how long does it take them to eat? If it's taking an hour to eat, I think it's worth a trial. So, I mean, that's very individualized. I think as a whole, the guidelines should be with the first bite of food.
Totally. Okay. Yeah, that's great. Thank you so much, Poppy.
So I'll just finish before, oh, Peggy, go ahead and ask your question. Okay, because I just have one more slide and then I'll leave you guys alone. This is just some take-home messages, okay? So number one, most patients are malnourished, sarcopenic, and or cachectic. And when you come to your office, they're already there. So let's take that into account. Most patients also have PEI and PERT at diagnosis. Let's not let it fester. And the people in this room are doing really well with that. A dietitian is well placed to help manage malnutrition and PERT. Refer. And number four, Canadian PERT guidelines are in development. Stay tuned. So that was it for me. Please invite you to ask me questions. Thank you.
Thank you very much. That was awesome. I guess just a couple of things, lots of things came up during your talk. I think the sarcopenia measurement on CT scans, there is software out there. Radiologists need to use it.
Yeah.
And we need to ask for it.
Software, there's Slice-O-Matic.
Is it Quebec? Yeah, I've heard this. Like, so we have one of our oncologists is very interested in obesity and sarcopenia. So she's been doing some research into that. Again on the on PERT, that again, one of the things that Ontario gets wrong, if you're between the ages of 25 and 65, you're not eligible for Ontario drug benefit. And PERT is, yes, there's a limited use code, but you have to be ODB eligible. So if you're not ODB eligible, you have to apply for Trillium, which is a deductible. We in oncology, we just find reasons for them to go onto home care, and then they get a card that way. But that's something that the ministry could just fix and make sure and remove barriers to these drugs they're not cancer drugs, but they are so important to cancer patients.
What is the point of giving expensive cancer drugs if patients are dying of malnutrition?
Yeah,
it doesn't make any sense.
Yeah. And I guess the only other thing I would be more forceful about for pancreatic cancer patients is the access to a dietitian. Every pancreatic cancer patient should see a dietitian, period, full stop. We in London, we have a dedicated dietitian. It took a fair bit for us to convince the powers of be. And this speaks a little bit to the power of philanthropy. What we did is, recognizing that this was a need, through our Baker Center, we funded a dietitian as part of a quality improvement exercise. We've got lots of data about how busy he was. The reports back from patients about how good he was doing, how his involvement has changed the lives of these patients. And thankfully I can report that our center has agreed to continue him in that focused 100% on pancreatic cancer. Fun fact for the province of Ontario, so all the hospitals, they respond to key performance metrics, right? So the one singular key performance metric for cancer centers, for dietitian nutrition services, is percentage of patients who have seen a dietitian, percentage of patients with head and neck cancer You've seen a dietitian. That's it. Everything else really doesn't matter.
Yeah.
Managing a head and neck cancer patient for a dietitian has to be obviously different.
Yep.
Managing a pancreatic cancer patient. So I think, in my view, for a tertiary care center, you should have a dedicated dietitian that sees all patients, that manages pancreatic cancer. And that's what the expectation should be, not just a dietitian if you think it's appropriate. Everybody should be seen by a dietitian and I think that the tools that are great, they are not a substitute for a dietitian. They will help. ChatGPT will help. It doesn't replace. PERT Calculator will help, but it doesn't replace. So I think that's I would just be more forceful in terms of the involvement of dietitians. So we're certainly believers of that in London and have fought for it. And I think that type of statement should be in any statements that are nationwide about the importance of a dietitian management in these patients' journeys.
I think it's wonderful that you guys took it upon yourselves to get that service within your practice and within your clinic, because even at the MUHC, Tertiary Quaternary Care Center, we have a dietitian who sees patients with pancreatic cancer, but also with breast cancer, with hematological cancers, with head and neck cancers. So she does her best to see everyone. She's only seen them pre-chemo. There is no one at this moment seeing patients preoperatively. I had a study going for a while, seeing patients preoperatively. That's done. There's no one in that clinic, in the surgical clinic. And we've been trying, rallying our managers, trying to get the dietitian, a single dietitian for those patients, covering the surgical oncology clinics. It's still in our center a struggle. So good on you. Congratulations. I think that's wonderful. And you're absolutely right. Everyone needs to be seen by a dietitian.
Yeah, I think Princess Margaret is actually formally studying this too as part of a research study, right? So I think data generation will be helpful. But yeah, I think there's his name is James Mulligan. I think we'd be lost without him. Yes, he can't prescribe, but he gives us little notes of how to prescribe and how much dose, and he always writes take with first bite of food, so we have to type it in because our electronic medical record still says before meals. It's so annoying. But anyway, thank you very much. This is great.
Thank you.
Jay, are you able to put that just so that everyone can see? So we have to do another survey, and that will be one of our, so this is the PERT calculator here. So it is still a URL. And we hope, we have in our strategic plan over the next 3 years to make it an actual app, but you can download the URL. So it would have that little guy, the little calculator would be on your phone, even looking like an app, even though it's still a URL. So it's been running for an additional year, so 2 years now. So it's time to put out in January another questionnaire to the users, but I think we have over 4,000 users that are using that PERT calculator from all over the world. So when we reviewed it the first year, we added Poppy is a huge person behind this all the food that you see there listed, amount. She's worked really hard on this calculator. So we added, I think, Poppy 63 new foods
based on feedback we got from patients that missing foods.
Yeah, so there's still an option. So they go in, they register, and then they can download the URL onto their phone so they don't have to keep registering. And they can, it's just like a Weight Watchers app or a, fitness app where you're just entering in your information instead of getting your calories or your weight loss or any of those calculations. You're being told how many capsules to take with a meal. So we did get feedback that the majority of the users felt like it was very user-friendly. Before it was going to different screens, and now he just has it as a scrolling checklist, which they said made it easier to use. So because it's a URL, we still sometimes will have patients tell Erin, or we'll get a feedback that it's spinning for a little bit because it's such a heavy website, like in the back end. There's just so much information. I was going to say something else, but that moment has passed. I don't know. But Poppy, you are, amazing, and we always love when you're a part of our presentations and all the work you've done with us. And we really greatly appreciate everything you've done.
Well, I'm honored to be part of this group, so it works both ways. Thank you, everyone.